All right, let's jump right into this explainer. We're tackling a beast of a topic today, the pharmacology of treating tuberculosis. This is one of those subjects that can easily feel overwhelming because of the sheer number of drugs and complex regimens, but by breaking it down logically, we're going to master it together. Here's our roadmap for this explainer. First, the tuberculosis challenge. Then, first-line TB drugs, managing adverse effects, standard treatment regimens, and finally, combating drug resistance. Section 1, the tuberculosis challenge. Why exactly is TB so incredibly hard to treat? Okay, so the main thing to remember here is that mycobacteria are just exceptionally stubborn. I mean, they grow really slowly compared to your standard bacteria. And the craziest part, they actually hide, literally lie dormant, right inside our macrophages. Yeah, the exact immune cells designed to destroy them. They just set up camp and create these chronic granulomatous infections. Because this bug grows so slowly and hides so well, treating it is arguably the most difficult bacterial challenge we face. The response to chemotherapy is just painfully slow. You can't just toss a quick course of antibiotics at this and call it a day, right? Which naturally brings us to a massive clinical question. Given this super sneaky dormant pathogen, why do we need to throw so many different drugs at it for months on end? Why not just hit it with one massive, powerful pill? That brings us to Section 2, first-line TB drugs, the primary solution. So we've got a really stark contrast in our pharmacological toolkit. On one side, we have our first-line drugs. These are the absolute go-tos because they pack the highest efficacy with the lowest relative toxicity. Basically, the best bang for your buck. But then you've got the second-line drugs. These are your reserves, they're less effective, way more toxic, and we really only pull them out in very special, usually pretty dire circumstances. To make this easier to digest and remember for the wards, look at how our four main first-line heavy hitters work. They attack from totally different angles. Isoniazid blocks mycolic acid, which totally wrecks the cell wall. Ethambutol also goes after the cell wall, but it targets a ribinosyl-transferase instead. Rifampicin? It bypasses the wall entirely to jam up bacterial RNA and stop protein synthesis. And then there's Pyrazinamide, which acts as a sort of tactical strike inside the acidic environment of the macrophage, killing those hidden bacilli. It's basically a coordinated, multi-pronged nightmare for the bacteria. By hitting the bacteria from all those different angles at once, we're nailing the core principles of anti-tubercular therapy. We kill the actively multiplying bugs, we flush out those sneaky, dormant persisters, and this is a big one, we prevent drug resistance. And we can only do this through combination treatment. Honestly, if you try using just one drug, the surviving bacteria will mutate and just become invincible to it. Moving on to Section 3, managing adverse effects, the complications of therapy. Now, heavy drugs come with heavy side effects. Just remember this delightfully grim mnemonic, R-I-KIP. It stands for Rifampicin, Isoniazid, and Pyrazinamide. Those are the three major first-line drugs that can cause serious hepatotoxicity, liver damage. Because of this, checking a patient's liver enzymes during therapy isn't just a polite suggestion, it's an absolute necessity. And beyond the liver, there are some very specific side effects you absolutely need to know. Ethambutol messes with the eyes, specifically causing retrobulbar neuritis, which can actually show up as red-green color blindness. Pyrazinamide can trigger hyperuricemia, meaning acute gouty arthritis. Oh, and Rifampicin, that one will completely panic your patients by turning their urine and tears bright orange if you don't warn them ahead of time. Seriously, give them a heads up. There's also a really elegant clinical workaround for a very common issue. Isoniazid is infamous for causing peripheral neuropathy, that tingling nerve damage in the hands and feet. It does this because it flushes vitamin B6 out of the body. So the fix is super simple. You just co-administer daily pyridoxine, which is vitamin B6, at about 10 milligrams alongside the isoniazid. Problem solved. But what if that RIP liver toxicity we just talked about actually hits hard? Say your patient suddenly develops jaundice mid-treatment. Their skin turns yellow. What's your immediate clinical move? You have to stop the drugs right then and there and check liver function. You absolutely cannot just push through it. All right, Section 4, Standard Treatment Regimens, Time and Strategy. To navigate those toxicities without letting the bacteria win, we lean heavily on standard World Health Organization guidelines. This treatment is never random. It's a meticulously calculated timeline designed to eradicate the bug while keeping the toxic load on the patient's body manageable. For a brand new case of pulmonary TB, the regimen is broken into two distinct phases. First up is the intensive phase. This is 2 months of highly aggressive therapy, using all 4 of those first-line drugs: Isoniazid, Rifampicin, Pyrazinamide, and Ethambutol, or HRZ. We want to rapidly clear out the actively multiplying bacteria so the patient is no longer contagious. Then we step down to the continuation phase for 4 more months. That uses just 2 drugs, usually Isoniazid and Rifampicin, to systematically hunt down and wipe out those dormant persisters. Now, 6 months is a really, really long time for anyone to take heavy, nausea-inducing pills every single day. So public health systems use the DOTS strategy. That stands for Directly Observed Treatment Short Course, and it means exactly what it sounds like. A healthcare worker physically watches the patient swallow every single dose. It sounds intense, but it is the absolute gold standard to guarantee compliance. Because when compliance drops, well, disaster strikes. And that brings us to Section 5, Combating Drug Resistance. What happens when therapy fails? When treatment fails, it is a literal public health disaster. Whether DOT supervision breaks down, a clinic runs out of meds, or a patient just stops taking their pills because they feel better, the surviving bacteria learn. They mutate. That suboptimal exposure to the drugs breeds drug-resistant strains, and suddenly a very treatable disease becomes incredibly dangerous. It's an escalating crisis. A patient graduates from standard TB, which we can treat pretty easily, to MDR TB, or multi-drug-resistant TB. That means the bacteria has outsmarted our 2 very best drugs, Isoniazid and Rifampicin. And if treatment fails again, it evolves into the absolute nightmare scenario, XDR TB, or extensively drug-resistant TB. At that point, the bug is laughing at both our first-line drugs and our primary second-line reserves. If someone develops MDR TB, we lose our best tools, and the treatment timeline just explodes. That 2-month intensive phase, it jumps to anywhere from 6 to 9 months of daily injectables. And the continuation phase stretches out to a grueling 18 months. That's up to 2 full years of relying on those highly toxic, less effective second-line drugs we mentioned earlier. The physical and financial toll on the patient is just staggering. Which leaves us with this provocative thought to wrap up our explainer. Given the severe clinical and global public health consequences of resistance, how can we better empower patient compliance from day one? We know the pharmacology works if taken correctly. The ultimate challenge isn't just in the chemistry of the drugs, but in supporting the human being taking them, ensuring they can finish the fight against one of the world's oldest and most stubborn pathogens.